Welcome to the emergency lecture on lower GI medications. This will be covering material in your book on chapter 34, and of course, as usual, follow along in your handout, which is in the usual place. What I'm going to do in this lecture is, it's going to be not very long. I'm going to give you a few definitions. We're going to just cover diarrhea and constipation, really, maybe a little bit about irritable bowel. There's lots of other lower GI diseases. You will come across them later in your career. We're just going to concentrate on these two major ones. I'm not going to give you a long list of drugs for this because at this point I just want you to learn sort of the few major drug classes and how they work and why they're different. So we'll do a few definitions. We'll talk about diarrhea, we'll talk about constipation. I might tell you a gross story in between, so you might not want to be eating, but otherwise it'll be the usual. All right, so first of all, what is diarrhea? What is constipation? So diarrhea is usually considered to be either very liquid stool or somebody's having more than 3 bowel movements a day. So normal is considered 3 bowel movements a day up to 3 bowel movements per week. So constipation is considered anything less than 3 bowel movements a week, or very hard, very firm stool, or inability to pass stool. So everybody's different. You may find people coming in to complain that they have diarrhea because now they're having 1 bowel movement a day and they're used to having 2 bowel movements a week, whereas somebody who's used to going 3 times a day might complain because they haven't gone in 2 days. So a lot of it might end up being relative. There's another very common disease in America called irritable bowel syndrome, or IBS, which is sort of an alternation between diarrhea and constipation. So somebody will be have constipated for 4 days or something, and then they'll have terrible urgent diarrhea. So but let's just concentrate on the 2 major ones for now. So first let's talk about diarrhea. So diarrhea has there's many things that can cause diarrhea. There's lots of infections that can cause it, viruses, bacteria. There can be a lot of drugs cause diarrhea. We've talked about some drugs that have the side effects of diarrhea. Diarrhea, as you'll learn later in your pathophysiology courses, sort of comes in 3 varieties. There's osmotic diarrhea. Now you guys know all about osmotic things, right? So osmotic diarrhea, it's like the osmotic that we used as a diuretic. So an osmotic is something that pulls water along with it. So osmotic diarrhea tends to be from either using drugs that are osmotics, or also it's fairly commonly seen in people that eat a lot of a certain type of food. So for instance, sugar alcohols in diet gum. So if you have somebody come in and they're complaining of new diarrhea, they don't really know why, and you see that they're chewing gum, and you ask them and they're chewing 4 packs a day of diet gum, sugar-free gum, that can cause diarrhea too. Then there's secretory diarrhea, which is most types of diarrhea, and that's basically the GI tract is secreting a lot of water into the GI tract because in response to either an infection or something that's irritating the GI tract or something like that. Oh, and then lastly, there's exudative diarrhea, which is related to things like inflammatory bowel disease, not irritable bowel disease. Those are 2 different things. There's irritable bowel syndrome, inflammatory bowel disease. Inflammatory bowel disease are things like Crohn's disease, and that's where the intestine is exuding things into the GI tract. So that's a different thing. So most of the things that you're gonna encounter, though, are going to be these secretory type of diarrheas. Now, the main thing that you want to think about when you're dealing with a patient with diarrhea is not necessarily dealing with the diarrhea immediately. Usually the thing you're most worried about is dehydration, because when your GI tract loses water very quickly, you not only are losing water, but you're obviously losing sodium, right? Because water always follows sodium. Additionally, because of the way electrolytes are transported in the bowels, you lose potassium as well. So this is really especially a problem with kids, because they get dehydrated very quickly because they're little. So when you have somebody who's dehydrated, you want them to be drinking fluids, as much as possible to replace their water. But you don't want them to just drink water. You want them to have some electrolytes too. That's why they have things like Pedialyte and some of the Gatorade type, sports drinks that have electrolytes in them. So again, the rehydration is usually the most important thing. People die of cholera not because they're pooping, it's because they're pooping out all their water. They'll lose 5 gallons in a day, so they get dehydrated like a raisin and die. So just before you even think about the other drugs for diarrhea, you want to make sure that the hydration is there. All right, now there's a couple different classes of drugs for diarrhea. Your book, again, has a really nice list of some of these. First of all, the opiates. We know from the section we did on opiate painkillers that opiates tend to constipate people, so they're very good for diarrhea. So they work by inhibiting the motility of the intestinal walls. Two very common ones that you'll see in the drugstore are Imodium and Lomotil. So Imodium is loperamide is the generic name, and Lomotil is a combination of diphenolate and atropine. Atropine is the anticholinergic we're all familiar with. It dries you out, right? So it's very good for diarrhea. The other two are opiates. They work by inhibiting intestinal wall motility and therefore help reduce the frequency of bowel movements. Now, a lot of people, including myself, think that if you have diarrhea because of an infection, so for instance, you have, stomach flu, or viral stomach flu, or you've eaten some bad potato salad or something and you have food poisoning, you don't really want that in your body. You want that to pass out of your body. So you don't necessarily want to stop the diarrhea, provided you're getting enough rehydration. That's my personal sort of view on that. Again, rehydration is a really important thing. But there are situations where you might have food poisoning and you have to be able to function, because you can't be like giving a talk to your company with poop running down your leg because you have horrible explosive diarrhea. So in those cases, it's a good idea, that's a situation where you might want to prescribe something like Imodium or Lomotil and say, all right, this is going to help stop your diarrhea so that you can do what you need to do. But it's generally not a good idea to be taking that stuff for more than a couple of days. If somebody's having diarrhea for a week or two, that's a problem, and something else is going on, so you don't want to be using that like that. Now, I have a couple other things on the handout here. One class is adsorbents. A common one is Pepto-Bismol. Another one is, I think, ketopeptate. But Pepto-Bismol, if you look at the marketing and the way it's labeled, you get the impression that it's sort of good for all forms of diarrhea, nausea, and any kind of GI trouble you might ever have. In fact, what Pepto-Bismol is doing is it's binding up whatever is irritating the bowel. So if it's an infection, it'll bind up the bacteria. If it's some sort of food that's stimulating, or some sort of natural product like senna or something like that, it'll bind that up so that it does not stimulate the GI tract for the diarrhea. If it binds up a bacteria, it means that bacteria is less likely to actually go through the wall of the GI tract and cause a systemic infection. So Pepto-Bismol is really good when you have an infection of some sort, or something really, a toxin or something irritating the GI tract. Pepto-Bismol is most commonly used, or most commonly probably prescribed by doctors for people that are traveling to other countries or areas where they're not used to the local flora. So that traveler's diarrhea that people get by drinking the local water of whatever country they've gone to. Sometimes you can prevent that to a certain extent with Pepto-Bismol, because the Pepto-Bismol coats the walls and adsorbs to the bacteria to prevent it from causing the infection. One other thing about Pepto-Bismol, which is bismuth subsalicylate, actually two things. It is a subsalicylate, so it's sort of, it has a chemical structure similar to aspirin. So if a person's allergic to aspirin, they might have trouble with the Pepto-Bismol. The second thing is that Pepto-Bismol can cause black stool, so it can make the stool turn black. If a patient's taking Pepto-Bismol and they make a stool that looks a strange color, it looks black, they go and look online, they Google black stool, and then they freak out because there's a particular kind of black stool called melena, which is sort of a tarry, very smelly kind of black stool, which indicates that there's bleeding in the GI tract. So the black stool that Pepto-Bismol makes is not the same as melena. So it's a good idea to warn your patients about it so that they don't freak out. In theory, if you've seen them and they're having poop troubles, you've already checked them to make sure they're not bleeding just through your general examination. So it should be okay to tell them not to worry if they see that. Some of these adsorbents not only bind up bacteria and toxins and irritants, but they sometimes bind up nutrients. that you're trying to absorb. So, for instance, cholestyramine is used specifically to bind up cholesterol and lower people's cholesterol when, if they have a high cholesterol level. But sometimes these adsorbents bind things that you don't want to bind. So again, it's not something you want to be using every day, but in certain cases, it might be a good idea. At the end of that table, I have an antispasmodic listed there, Bentyl, which is dicyclomine. Again, irritable bowel syndrome is something where people are constipated and then they suddenly have terrible diarrhea, so sometimes you might use an antispasmodic. Antispasmodic is just another word for something that sort of relaxes the intestinal walls. Right? It's something that sort of relaxes things. And your book mentions also some anti-serotonin drugs, which were originally used for chemotherapy-induced nausea and vomiting, and then became things that were also used for irritable bowel syndrome. So those are just a few of the classes. So again, what I want you to come away with here is just to know the classes and sort of know how they work. Okay, so that's diarrhea. How wonderful. All right, so let's talk a little bit about constipation, because everybody wants to talk about constipation. Before I tell you about constipation, I'm going to tell you a gross story. So you can fast forward if you want to hear a disgusting story. So this happened when I was an intern in Baltimore. I was a medical intern. And I was working, I think I was doing my ICU rotation, and we got this patient referred to us from a nursing home with the diagnosis, which is not a diagnosis. The diagnosis was rule out stomach tumor. So this patient came in. She was a little teeny tiny old lady in her 80s or something, 90s. Real skinny little lady, except her stomach was huge. It was like, she looked like she was 9 months pregnant with twins. She was huge and firm and stiff. And all I could think was, wow, if this is a tumor and they haven't sent it to us until now, that's, wow, they're really not paying attention to their patients. But anyway, so the first thing we did was do an x-ray to see if we could see what was going on in her stomach. And her stomach was filled with poop. Not her stomach, her abdomen was filled. All her bowels were just distended with stool. So the problem there is that she had clearly not had a bowel movement in a long time because she was completely filled with poop. And when a person gets that backed up, what will happen is the stool that's sort of closest to the anus gets really hard and dry, because the whole point of your large intestine is to, reabsorb water. You get that water back from the inside the intestine. And if you let the stool sit there long enough, so much water comes back that it just dries it out. And if you have a big stool that's rock hard, there's no way that the patient's going to be able to pass that on their own. There's no way. So what do you do in that situation? How do you get it out of them? So the way you do it is with with a process called disimpaction, which is a fancy word for saying that you put on a long surgical, some sort of gown, protective clothing, some long rubber gloves, and you get some KY jelly, and you lube up your hand, and you just stick your hand in, and you start pulling out the stool. Fortunately, I have very nice, thin hands, and so hopefully it wasn't too horrible for my patient. Fortunately, she was obtunded. She was, unconscious, probably due to having her stool backed up for a month. So she didn't suffer through this experience. What's interesting is you don't actually have to reach in all the way around to get all the stool out, because once you sort of manually, once you get rid of the blockage and you're stimulating the rectum manually, then the intestines they cramp up and they push everything else out. So this poor woman, we got 3 entire bedpans filled with stool came out of this poor woman, and it looked like the scene from Close Encounters of the Third Kind, because it was like sort of mountains of stool. And when the stool's been in a person's body that long, it doesn't smell bad or anything. It's like chalk almost, or dirt. And by the time we got everything, once she passed everything, her stomach was completely flat. So she went from 9 months pregnant with twins to completely flat. So we went back and looked at the records. There's a point to this story. We went back and looked at the records, and it looked as though what had happened was she had complained of being constipated. And she had been given milk and magnesia, I think twice a day. This has been 20 years now, so I think it was twice a day they were giving it to her. And this had been going on for weeks. So for weeks there were notes written saying, patient complains of being constipated, prescribe, given milk and magnesia, for constipation. But nobody had ever checked to see if she'd pooped. So this is an important lesson for nurses and wannabe nurses, is that if you write a prescription, if you give a patient something for constipation, find out if they pooped. Don't just wait until 5 minutes before the end of your shift and ask, and then say to the person after, you're like, oh, she didn't poop, you better do something. That's not cool. Because it's way easier to deal with somebody who's been constipated for 4 days by giving them an enema or something than having to have them go through the misery of going to an intensive care unit and being disimpacted. So that's that story. All right, so now you've learned the incredible importance of knowing how to deal with constipation. Now, in America, there's sort of 3 main causes of constipation for people that are healthy otherwise and aren't on drugs or aren't on medications, excuse me. So the most common causes are lack of fiber in the diet, lack of fluids in the diet, and lack of exercise. So you need fiber in your diet, especially insoluble fiber, because that helps bulk up the stool and helps draw water in, and helps keep the stool nice and squishy, so that it's easy to pass. That being said, if you're going to take fiber supplements, or if you're going to increase your fiber in your diet, you must increase your water in your diet as well, your fluids in your diet, because if you just take fiber supplements and no water, you end up with having a rock usually sitting in your stomach. It's called a bezor. That actually happens, and that is much more difficult to get out than an impacted stool. And then exercise, because as you're moving around throughout the day, the muscles of your abdomen are sort of massaging your intestines and sort of squishing things along, which is why when we see patients in the hospital, it's so common for them to be constipated, because now they're stuck in bed, they're not moving, and so their bowels aren't moving properly. So it's very common for patients to be constipated in the hospital. Now, other causes of constipation include drugs. Now, we've already covered a bunch of drugs that cause constipation. The opiates we already mentioned. We should have already mentioned calcium channel blockers, right? Epic constipation with those. Anything that's anticholinergic. And we talked about aluminum, antacids, calcium. Antacids can do it as well. So there's lots and lots of drugs that can cause constipation. Another thing that can cause constipation, and you'll see that with your teenager eating disorder patients, is overuse of laxatives. So you'll see that movie stars sometimes will go to these clinics. I guess in California they have these clinics where you can get colonics, which is just a fancy word for an enema, because people think that if they get an enema or a colonic, it will cleanse them of their toxins. Actually, by shooting water up there or saline, you're actually messing with the lining of GI tract. You're probably getting more of a rush of bacteria and toxins into your body than if you just let nature do its job and just pass your toxins normally, as you normally would. Take my nutrition course if you want to hear my rant about all the crazy products on the market. Anyway. But what will happen is these movie stars will go and get colonics before a red carpet event because it'll make their stomach flat. So of course that has gotten into the literature of the eating disorder people, and they all think, oh, I'll use a laxative, it'll make my stomach flat. Also, when you use a laxative, you lose water weight, so you look thinner on the scale. The problem is that when you overuse laxatives and you use it day after day after day, your body actually starts to become dependent on them. And then if you stop taking them, you get epically constipated. It's particularly true for the stimulatory laxatives that we're going to talk about. Not so much for the other ones, but stimulatory ones are the most common cause of that kind of thing. There's also a bunch of different medical conditions that can cause constipation and other causes as well. So how to fix constipation? First thing to fix it, if there's no known cause, it's an outpatient person who's just complaining that they're constipated, is just talk about fiber and water and exercise, that kind of stuff. That's fixing somebody's diet is probably the easiest thing to do. Adding oatmeal to somebody's morning routine can be life-changing. So I highly recommend it if you'd like to be trying it. Do keep in mind that if there's any chance the person's bowel is obstructed, you don't want to give them a laxative, something that's going to stimulate the GI tract. I'm creaking here. The GI tract, because if there's an obstruction, you don't want to push against that. So, but most people don't have that situation. All right, so there are good reasons to use laxatives. Okay. All right, so if somebody is acutely and unusually constipated, so it's something new, so that's a good thing. You're going to find laxative use also in the hospital as a pre-treatment for colonoscopies and GI procedures. So that's another good reason to do it. And the other reason to give somebody a laxative or stool softener, something like that, is to prevent straining at stool. So, for instance, if you have a patient who just had abdominal surgery, maybe you don't want them like doing the Valsalva, straining to poop right after their surgery, because you don't want them to pop a suture. So you don't want them to bleed, whatever. So there's going to be all different reasons that you're going to see laxatives or something to relieve constipation given in the hospital. All right. Again, for this, I just want you to sort of know the major classes of anti-constipation drugs. I'll give you a couple common ones to know, but don't get too anxious about this. All right, so some common anti-constipation medications. First, we have the bulk forming agent. So I have an example here is psyllium, which is in Metamucil. All right, so this is usually just insoluble fiber. All right, it's just non-digestible plant material. You can't digest it. All it does is it adds bulk to the stool, and it helps soak water up with that bulk, and it makes the stool more squishy. I don't recommend that you do this with stool. That would be kind of weird, but what I'm just saying is that you want the stool to be soft so the patient can pass it easily. Metamucil, I should just mention, I think that's the one that's orange. It comes in a container like this. I think that's the one. And you're supposed to, the way you tell the patient to use it is you stir it into a big glass of water and they drink it. And the reason that they take it that way is specifically to make sure that the patient's drinking water with it, because if they just take spoons of Metamucil, they'll end up with one of these Bezors, which is no good. It's not good. That happens. All right. Secondly, there's the next class of drugs here is the stimulants. So these are those drugs that are always advertised as gentle overnight relief of constipation. So these are things that irritate the bowels so that they constrict more vigorously, and that helps pass the stool. So there's one called Ducalax that I've seen in the pharmacy, and there's also all sorts of natural ones. You know how I don't like the word natural. I don't like the word natural. Everything's natural. But you will see some natural type stimulant supplements like cascara and senna and castor oil and these things, and they work. It's fine, but just be aware that they're stimulant type laxatives. So if you're using them every day, you're going to get your bowel will become dependent on it, and then you're sort of stuck taking it. And when you get off of it, it's not fun. So just don't. That's something to use once in a while, not all the time. Then there's stool softeners. The most common one you're going to come across in the hospital is Colace. Colace is, I think, over the counter now. You can just get it. And again, it's just something it does what it says. It softens the stool and makes it easier to pass. People also use mineral oil. I think that seems gross, but people do it evidently. If you decide you want to use mineral oil as a stool softener, make sure that you buy the pharmacy grade mineral oil at the pharmacy and not the mineral oil like at the hardware store. That's not the good stuff to use. Mineral oil is also good for keeping your cutting board, wooden cutting board, nice and shiny. So it has many, many uses. All right, then there's the hyperosmotic laxatives for constipation. The most common one, or the one that I'm going to mention here as the one I want you to know, is milk of magnesia, because remember we learned that as an antacid, and it's an antacid that has the side effect of causing diarrhea because it's a laxative. It's got magnesium in it, and so you want to be careful with kidney patients. You don't want to give that, you don't want to overload a kidney patient with magnesium. That would not be nice. Now, there's another one called magnesium citrate. I'm told that it's like an atom bomb, and which seems very drastic, but that's supposed to also clean you out in a much more vigorous way than milk of magnesia might do. What else do we have here? The glycerin suppositories, that's working again. It's a suppository, it's given rectally, and it acts to draw water into the rectum, and also I think it irritates the rectum a little bit, and that's supposed to work quite well. The Fleet enema, enemas are just little bottles of saline, basically, that you can squirt up into the rectum. Again, it's the fluid is going to help moisten a stool that might be too hard to pass otherwise, but it's also going to be expanding the rectum, so that stimulation, that mechanical stimulation, will cause expulsion of the stool. All right, then there's polyethylene glycol. Now there's a over-the-counter osmotic called Miralax, which I think is polyethylene glycol. I know it's polyethylene glycol. People often use that sort of the same way people would use milk of magnesia, but it doesn't have the magnesium issues. There's also a polyethylene glycol solution. There's one called PEG. There's one called Go Lightly. There's a whole bunch of them, which come in big, like, gallon bottles. And those are things that you give to patients prior to a procedure, so that it'll clean out their GI tract, so that it'll be easy to see what's going on under a colonoscopy. Okay. All right. So again, diarrhea and constipation are the two main categories of drugs I want you to know. Don't worry about all the other diseases like Crohn's disease. There's all these other diseases that we're not going to cover in this class. Just know the major categories, and of course any bad contraindications you want to know. All right. Hopefully I'll see you in class if the water subsides from the flood.